First of all, I would like to thank Tufan for his kind invitation. I feel deeply honored to be here today as a faculty of this interesting workshop on the management of female stress urinary incontinence after a failed mid-urethral sling. Well, these are my disclosure. I have to admit that my travel expenses and accommodation expenses have been covered by the International Continence Society because I'm sitting in the board of a trustee, so I'm really thankful to ICS. What we know today about management of female stress urinary incontinence after failed mid-urethral sling? Well, we know that is not a rare case, and it has been reported to occur in up to 16% of the cases. And we also know that the treatment options include both conservative management with pelvic floor muscle training as well as surgery. However, if we look at the data reported in the literature, there is the Cochrane libraries that are telling us that now, to date, there are no data to recommend or to refute any of the different management strategy for recurrent or persistent stress urinary incontinence after failed mid-urethral sling. So we can have a nice interactive discussion between us. We can share our opinion, but unfortunately we have all to admit that the literature is still lack of evidence, and high quality of randomized controlled trial are obviously needed. What do we know about pelvic floor muscle training? Yes, if we talk to our healthcare, our pelvic floor training, our physiotherapists, they will tell us that pelvic floor muscle training should be recommended as a first-line treatment for both primary and secondary stress urinary incontinence. And we also know that if we look at the clinical guidelines of the Society of Obstetrics and Gynecology in Canada, they also recommend pelvic floor muscle training in these population of patients. If we look in UK, a national survey conducted in UK reported that 77% of healthcare providers will recommend the use of pelvic floor muscle training before undergoing any continence surgery in patients who have stress urinary incontinence after a mid-urethral sling. However, to date, there is still no evidence that performing pelvic floor muscle training in patients who have failed stress urinary incontinence is really effective. What about pubovaginal sling? Well, pubovaginal sling, we all know, has been in the past used as a procedure of choice after failed incontinence surgery, with a reported subjective cure rate of 86% of patient. We also know that for pubovaginal sling, we need to harvest a rectus fascia or a fascia lata to create a hammock at the level of the bladder neck of the proximal urethra using a combined abdominal and vaginal approach. What is the success rate of pubovaginal sling in female population with recurrent stress incontinence after a failed mid-urethral sling? These are the data reported in the literature. As you can see, that although there is no strong evidence how we should manage this patient, in the literature we know that pubovaginal sling might treat the stress urinary incontinence between 50 and 76% of patients with a follow-up that range between 14 months and 5 years. So we also know that pubovaginal sling for recurrent stress urinary incontinence are equally effective of mid-urethral sling, but we also know that they have a higher complication rate compared to the mid-urethral sling. Most of the patients report urgency after this procedure in up to 30% of the case, and the obstruction, which might require CIC, it has been reported to be up to 20% of patients. Normally, the urine retention resolves after 4 weeks in 60% of patients, but 15% of patients who have voiding difficulties will require a reversal surgery. What are the conclusions based on the data reported in the literature? Well, we know that patients with recurrent stress urinary incontinence following a mid-urethral sling represent a complex patient population. We also know that the treatment of choice, despite the fact there is lack of evidence, depends on a multitude of factors, mainly what is the surgeon used to, what is the preference and the training of the surgery, as well as the coexisting urological problems that might be present. There is still limited data in the literature, but we know that mid-urethral sling as well as pubovaginal sling in this subpopulation of patients are equally effective. A recent meta-analysis of 15,000 patients confirmed as well this data. There is no consensus based on the Cochrane review, and there is still no high quality of study that is able to provide us guidance in this population. If we don't know what to do, then I feel that we should agree with the fact that pubovaginal sling should be the first line, the first choice in patients who have concomitant urethral diverticulectomy. If they have a urethral fistula, if we treat the fistula at the same time, we should not put a mid-urethral sling, but we should try to treat our patient with pubovaginal sling. If a patient has a history of previous pelvic radiation or concurrent mesh erosion, we should try to avoid synthetic mid-urethral sling. This patient, we should agree with the fact that must be managed in a tertiary referral center based on the fact that in the right hands there are good subjective, good objective cure rate reporting in between 60 to 80% of our patients. But we have to counsel our patient properly, considering the fact that complication rate in this patient has been reported up to 18% of the patient. In conclusion, I can say that the autologous fascial sling can be still considered as a valuable surgical option for both primary and recurrent stress urinary incontinence in patients who have failed to mid-urethral sling. We need to properly counsel our patient about the complication rate, and we need to be sure that, considering the fact that synthetic mid-urethral sling in some countries are disappearing and the number of recurrence are increasing, we should start training our fellow and our resident with hands-on workshop as well as cadaver lab. Thank you for your attention. Now, before I leave I would like to present a case, and I hope you can help me better understanding as this patient should be treated in your opinion. This is a patient, he's a 67 years old patient who had one spontaneous vaginal delivery in the past, a total abdominal hysterectomy, and in 2004 ended up having a synthetic mid-urethral sling. The patient came to our clinic complaining of urgency, hesitancy, leaking urine all the time, complaining pain when passing urine, and complaining of vaginal discharge. When we examined the patient, there was a mesh erosion which was palpable, lateral to the urethra, and we suspected as well the presence of a uretrovaginal, a vesico-vaginal fistula. Now my question to you, how will you manage this patient? Don't be scared. We need to be interactive. We need to share our opinion. Any idea? What will you do? Sure. So he's a patient who had a TVT in 2004, come to see us. Wait, I'm leaking all the time. There is a vaginal discharge. We examine the patient, and the patient, we can see the erosion, and we suspect a fistula. What will you do? Cystoscopy. Any other idea? Urine culture, if there is an infection. Again, we examine the patient, we could see an erosion, and we suspected a fistula. Sorry? Correct, we need to. The fistula. So we should do the imaging to assess whether or not the fistula is there, because otherwise our management will change. Any idea? I think it's over. Oh no, there's no point. Okay, let's see. Yeah. Yeah.
Can you please a little bit explain your local physical examination findings?
Sure.
Do you suspect of any pelvic abscess in these patients if you have a so sensitive vaginal or groin area?
Okay, on vaginal examination, there was just sign of vaginal discharge, and there was an erosion visible. The patient had the TVT in 2004. We didn't suspect the abscess, but obviously that has to be ruled out. So maybe the imaging, to funny saying, maybe imaging will be required. I agree.
1, 2.
We don't know. This is how the patient comes.
We have a question from Australia.
Well, no, you wanted to, what would we do?
Correct.
Okay, so you've got a complex situation. It's a terrible situation. You're going to need a fluoroscopic urodynamic study.
Correct. So urodynamic
You're
study.
going to need cystoscopy. So you're going to have to carefully work out what's going on with this patient's bladder function. You've got to work out whether the urethra is salvageable, what you're going to have to do about the bladder, what you're going to have to do. So you've got to get rid of the mesh, number one.
We're getting there. So, investigation. So, our colleagues from Australia is saying we need to do a complete workout to understand fistula is there, yes or no. We need to do urodynamics diagnosis, urodynamics to understand is there anything else that we have to do to treat this incontinence. We need to do a cystoscopy, someone said, because we need to understand if there is a fistula or an erosion, we need to exclude if the erosion is inside the bladder or inside the urethra, right?
Helen, what type of imaging would you do in this patient?
I mean, she's really a mess, isn't she? So your fluoroscopic urodynamic study will be a starting point. You're going to have to think through what you're going to use to deal with the fistula and the residual urethral dysfunction.
Great.
So I'm thinking maybe I'm going to be closing the bladder neck. Maybe I'm going to be putting in a fascial sling to support my fistula repair. So, you know.
So we all agree. So we need video urodynamics to understand the voiding function, the filling phase. We need to understand if there is a fistula, if there is an erosion, and where is this tape. And when we made the final decision, maybe we can decide for our management. Yes, David?
I would like to add that in this case, because we suppose that she might have erosion, not extrusion. Erosion.
Yes,
the tape should
there is an extrusion.
But if this was not the case, I would perform ultrasound, because ultrasound will allow us to identify the proper size of the tape, and if the patient is incontinent, we might know whether or not the tape was properly implanted.
Okay.
Because if the tape is in the right place, close to the urethra, in the mid-urethra, then there's no sense to perform another tape. That's my opinion.
Agree.
I have a question. So you said, Helen, you're going to do like a video urodynamic in this patient.
Yeah.
But why are you doing a video urodynamic? Why are you asking from the video urodynamic? How can you read a video urodynamic with a foreign body object there, with a hole into the potential hole into the system? So what are you expecting to obtain out of your video urodynamic?
Okay, so it's going to enable me to systematically evaluate bladder storage function, residual intrinsic sphincter deficiency. So if the bladder neck's wide open, that's going to figure into what I'm going to do. You may actually be able to document with your fluoroscopy your fistula. I don't have any problem with adding ultrasound to it.
Can I
to
stop
work out
everyone?
What's happening.
Because we have to hurry up. Yeah, thank you very much. I completely agree with your plan. And this is what we did. We did video urodynamics. Video urodynamics will allow you to do a cystometric mictogram and understand there is a fistula, yes, no. Urodynamics will allow you to understand if there is a normal voiding phase, there is high post-void residual, is there any urodynamic stress incontinence, and so on. Is there any other condition of the bladder which might be treated? We did retrograde uretrocystogram. We did an EUA with uretrocystoscopy because we wanted to understand where is the tape, only in the vagina or is in the bladder or is in the urethra. And obviously we discussed the case at the multidisciplinary team meeting to decide what should we do. This is what we found during the examination. We found that there was a urethral fistula. When we tried to do the cystoscopy, this is what we found. We cannot get in. We cannot get in. As you can see, this is the urethra. It's not the bladder. So the tape was transecting the urethra, was getting in from the left urethral wall into the urethral lumen, right urethral wall. We managed to get into the bladder, and there was a vesical vaginal fistula. You can see the tract inside the bladder. So, on examination, the tape was transecting the urethra, but was no adherent. There was a bilateral uterovaginal fistula. We were unable to carry out the cystoscopy because it was obviously obstructing the urethra. It was a stenosed and retracted bladder neck because this tape was there since 2004. Therefore, the bladder neck was stenosed and tight. Video aerodynamics was difficult catheterization. There was severe urinary incontinence, was fixed urethra, low maximum urethral closure pressure, and the urethral vesical vaginal fistula was confirmed. Any idea how to manage this case?
Alex, can I just interrupt you for a second? So
Sure.
We still have a problem in why are you doing a video urodynamic, like a urodynamic study to assess the bladder function if the bladder has a hole in it and the urethra has a hole in it and you have an infection? What are you getting out of this?
Now, the reason why we did video urodynamics, because in our clinical practice it's easy if we do video urodynamics than to order a retrograde uretrocystogram. So the aim of video urodynamics is to do a retrograde uretrocystogram for that point of view. So we normally do ourselves. When we do the retrograde uretrocystogram, we normally do a uroflow, a post-void residual. So it's part of our clinical practice. But I agree with you, you might not need to study the filling phase because you might need to deal with the fistula first. So this is what I've done. Will you insert a suprapubic catheter to rest the tract? Who will? Who will insert a suprapubic catheter to rest the tract and then maybe see what happened later on? Anyone? Good, because we didn't do it. Will you do an MRI pelvis? Exactly. We did it because we want to understand if there was anything else missing. Will you remove the mesh only? So who will remove the mesh only, leave the catheter, and then correct the fistula? No one. Great, because we didn't do it. Will you discuss at the MDT meeting?
Yes.
Correct, because we did it. Will you have done a first stage procedure to deal with fistula and stress urinary incontinence at the same time? So will you remove the mesh? Will you correct the fistula? And will you repair the recurrent stress urinary incontinence? How many of you will you have done everything in one stage? No one?
I couldn't, but I would do a march flap at the time of correcting the fistula, and sometimes that procedure is enough to promote continence.
Great.
I would also do the first two things. Not
So
the
remove
last
all the mesh,
one. Remove the mesh and
correct the fistula,
Yeah.
and the martial flap. Great, because this is what we've done. Who will do this in two-stage procedure then? Few people.
You want to say why? You want to comment?
I think I'm agree with Dr. Castro. We will perform also the
Marsh.
situation. And I agree, I never perform urodynamics because if you need, you are not going to say how is the bladder after you correct the fistula. So you don't, we don't perform urodynamics. And
So you correct the fistula, you don't
we
correct
the
stress
fistula,
incontinence.
and then
You wait and then
you
do
wait
later
the
on.
symptoms. If you have stress urinary incontinence, how is the urgency,
And
how
then you
is
will-
the
So
pain,
you will do a two-stage procedure.
and then you will do.
Again here, what David said, will you do a Marshall's flap? Yes, we did it. Who will do a pubovaginal sling?
When? Right away or later?
Right away, David? You will wait. You will wait and see. You will at the same time, Tufan. You will wait and see. Anyhow, we did wait. We did the we correct the tape. We removed the tape. We corrected the fistula. And we did a Marshall's flap. This is what we've done. Thank you very much for your attention.
How long do you wait for the second operation?
For
the vaginal sling?
Yes, we're waiting. Normally, we review the patient in 6 weeks' time, but we will not treat her before 3 months.